Okay, we're starting. So it gives me great pleasure. My name's Ingrid Van Beek, and I'm the new chair of NCCRED, having taken over from the legendary Professor Margaret Hamilton in July this year. So it gives me pleasure in that role to open the symposium today. I'd also, on behalf of NCCRED, like to acknowledge country. I'd like to recognise the traditional custodian of the many lands on which we meet today, and extend my respect to elders, past, present and emerging, and also extend my respect to people who are participating in today's symposium. As you'll have seen on the program, it's a really great program. We're very proud of what Nadine and her fantastic team have put together. And I should also take this opportunity as the new chair to say that I'm incredibly impressed with the work that is coming out of NCCRED. It's a really inspiring organisation, led very competently by Nadine, and also, of course, with a fantastic team of people working with her too. So credit to them for putting together what is a very great lineup today, focusing on innovations in the therapeutic practice for methamphetamine disorder. And in keeping with the aims of NCCRED, this will give a fantastic opportunity to collaborate, to build and expand research networks and capacity, generate the best evidence-based knowledge, and translate the latest research into best clinical practice. And certainly as somebody who has straddled both the research and clinical field, I think those aims are admirable, and certainly the lineup today is going to enable that to happen in this really, ongoing important area of methamphetamine disorder. Also noting that it's a great opportunity for us to showcase some of the people who have had fellowships through NCCRED and research grants. They'll also have the opportunity to showcase their work during today's program. So it now also gives me pleasure to hand over to Wayne Williams, who is the coordinator of Indigenous health curriculum at the University of Queensland in the rural clinical school there. So he's going to do us a more formal acknowledgement of country. Thank you, and over to you, Wayne.
Thanks, Ingrid. Yes, thank you for the opportunity to provide an acknowledgement of country. So, as we say in my country, Wandjina, which means welcome, and I'd like to pay my respects and acknowledge country for all the different lands that we're meeting upon today across this great country. I'd like to acknowledge our elders, both present, past and emerging, but also acknowledge your work as NCCRED and as individuals towards addressing the health needs of Aboriginal and Torres Strait Islanders right across this country. Traditionally, Aboriginal and Torres Strait Islander medicines are based on the nature of the land we walk, the medicines that are provided us through the Great Spirit. But at times we need to supplement that, and I think, as I said, the research and the great work that NCCRED is sponsoring and doing and supporting Aboriginal and Torres Strait Islander people is a great service to our mobs, and we appreciate that. But again, thank you, and I also acknowledge any Aboriginal and Torres Strait Islander people in their country who are on the symposium today, and acknowledge any sorry business that is happening across country. So again, thank you for the opportunity, for the acknowledgement. Have a great symposium, and thank you very much.
Thanks so much, Wayne, for that introduction, and greetings from Sydney, from Gadigal country here in Sydney. And I also want to pay my respects to elders past, present and emerging, and recognise that sovereignty was never ceded. So thank you for joining us today, and thank you for any Aboriginal and Torres Strait Islander people that might also be with us today. I'm really excited to be presenting today's symposium. I looked at the run-up and I thought, this is a really great symposium. I'd like to attend. So I hope other people have the same kind of response. It is slightly odd that we're on virtual virtually. We're all pretty used to it by now, and it does certainly have the convenience of being able to have it on at your desk while you're doing your emails when you get a bit bored or check out, and people can still get hold of you. So, but you will miss out on the lunch. But thank you anyway for joining us. And I'd just like to thank also our consortium partners, so St Vincent's Health Australia, University of New South Wales National Drug and Alcohol Research Centre, NCCRED, that's the National Centre for Education, Training and Addictions, based at Flinders University, and NIDRI, the National Drug Research Institute, based in Curtin in Western Australia, and all of our board members, some of whom I know are with us today, as well as the chair of the National Clinical Research Network Working Group, Robert Ailey. Really happy that everyone's kind of mucking in to help us get somewhere with treatment of methamphetamine use disorder and being able to translate those treatments into practice. To start up today, I'm really happy to be introducing an international speaker, David Goodman. He's faking being in Venice Beach there on the screen. He's actually here with us today. We're really fortunate to have him in the country. We'll have to talk to him later about how he managed to actually fly in, because that must be a feat in itself at the moment. He's done his quarantine. We actually can get to see him face to face. So I'm really happy that he's here today. David, I'll let you describe who you are to everybody, because you'll do it better than I will. But thank you very much for joining us today.
Okay, thank you, Nadine. And it's really a pleasure to be here in this beautiful country and with this beautiful weather. So I'm David Goodman Meza. I'm a Mexican-American physician scientist. I'm actually primarily trained in infectious diseases, and I'm an assistant professor in the Division of Infectious Diseases at UCLA. COVID has made us extremely popular during this time in the hospital and elsewhere. Seems like I've never been more popular, never gotten so many phone calls, and never heard so many stories of potential exposures to COVID and what to do next. But really my research portfolio is at this intersection of infectious diseases and substance use disorders, where of course we know that people with substance use disorders have an increased risk of acquiring infectious diseases, but also for worsening outcomes when they have these infectious diseases. So my research portfolio is really around how to improve the lives of people with substance use disorders to ultimately prevent or improve outcomes of infectious diseases, particularly HIV and hepatitis C. We have several different studies in LA. I could go on and talking about them, but I think today it's really about methamphetamine use disorder. And so I would really like to thank the organizing committee for the invitation to present. And I really enjoy the possibility of talking in this rapid fire format. I will be presenting our upcoming trial, CTN 110, which is a randomized placebo-controlled trial of monthly injectable buprenorphine for methamphetamine use disorder with co-occurring opiate use disorder. So as everyone in the audience likely knows, and reason why we are here, I mean, Australia and North America lead the world in amphetamine use and consequently the substance use disorders that they cause. And this, of course, leads to significant individual, family, and public health impacts across our nations. In the US, the main topic of discussion related to substance use disorders for the last 20 years has really been the topic of opiate use. And rightly so, with over 50,000 deaths related to opiate use in the recent years and the large increase related to the introduction of fentanyl, mainly since 2013. Yet, America is really a tale of two countries, and this was especially highlighted in the recent election, right? So as we see in the map, and I guess we've all become experts in US geography following the election coverage, overdose deaths in the western part of the United States are really predominantly due to methamphetamine use in comparison to opiate use and particularly fentanyl use in the eastern part of the country. Interestingly, there is not a Democratic-Republican correlation with any particular drug. I'm part of the NIH NIDA's clinical trials network, in particular the Big South West node. And this node is led by Madhukar Trivedi and Jennifer Potter from UT Southwestern in San Antonio, Texas, and Steve Shoptaw, who's my primary mentor at UCLA. And I mean, our team has led or developed in recent years multiple clinical trials related to opiate use disorder or methamphetamine use disorder. And recently we completed the largest pharmacotherapy trial for the treatment of methamphetamine use disorder to date, using extended release naltrexone plus high dose bupropion. This is CTN-068 or ADAPT-2. And the results are forthcoming. So hopefully we'll be able to share those with you soon. But putting that aside, we're currently developing 2 protocols for stimulant use disorders, CTN-109 for cocaine use and CTN-110 for methamphetamine use, which is really the object of this presentation. So CTN-110, short name MERB, is a phase 2B double-blind randomized placebo-controlled trial where really for adults with moderate to severe methamphetamine use disorder and co-occurring mild to moderate opiate use disorder. And we will be testing injectable buprenorphine delivered by subcutaneous injection every 4 weeks compared to placebo over 12 weeks. And really, why is this important? Well, as again, the audience probably knows, there is yet to be an approved broadly effective pharmacotherapy for stimulant use disorders. There has been recent trials with promising results. Mirtazapine has been shown to decrease methamphetamine use in 2 small trials in men who have sex with men, and most recently by Phil Coffin in San Francisco. ADAPT-2 was recently completed. The results are currently in review, and again, we hope to share these soon. And then finally, CURB-1, which was led by Walter Ling, which tested extended release naltrexone plus sublingual buprenorphine for cocaine use disorder. And this study really showed a modest, though significant reduction in urine verified cocaine use among those adherent to oral bup compared to placebo, and really serves for the rationale for using kappa antagonists for treating stimulant dependence, in this case, methamphetamine use disorder. So why would this work? Buprenorphine, well, is a well-known mu opioid receptor partial agonist. However, maybe lesser known to many of us is that it's also a kappa receptor antagonist. And kappa receptor antagonism is known to reduce dysphoria and produce a sense of well-being. And this is being studied for treatment of refractory depression and PTSD. And really, this kappa antagonism is thought to produce these antidepressant effects. And our hope is that this effect would really impact the negative affect and the withdrawal of acute methamphetamine use, essentially impacting this so-called dark side of addiction. So our primary objective is to evaluate whether assignment to 12 weeks of outpatient injectable bup compared to 12 weeks of outpatient injectable placebo reduces methamphetamine use as measured by twice-weekly urine drug screens during weeks 9 to 12 in participants with moderate to severe methamphetamine use with co-occurring mild to moderate opiate use. And really our hypothesis is that injectable bup will produce a significantly greater number of negative methamphetamine urine drug screens compared to the placebo arm. So we're including adults 18 to 65 years of age interested in reducing or stopping methamphetamine use, and they have to meet DSM-5 criteria for moderate to severe methamphetamine use disorder, so 4 or more criteria. And then they have to be able to provide at least 2 urine samples positive for methamphetamine within a 10-day period, but this period can be actually extended up to 21 days. And then for opiate use disorder, we're really trying to find people who have a mild to moderate use disorder, and they're actually able to produce 1 negative screen during this screening period. So this is what the study will look like. We're planning to enroll 246 individuals and randomize them 1-to-1 to the placebo and the injectable bup arm. Again, the screening period over from 10 to 21 days, where we're going to require at least 2 positive methamphetamine urine drug screens and at least 1 negative opioid drug screen. Then participants will be randomized 1-to-1 to the placebo arm or the injectable bup arm. Induction is going to be a little bit different than standard practice, where we're going to really try to do rapid induction, escalating sublingual bup over 3 days, and then dosing with injectable bup at a dose of 300 milligrams over at week 0, week 4, and week 8. And then we follow up at week 12, again, between weeks 9 and 12, we'll be testing for our primary outcome. And then we have another follow-up visit at week 16. These are the different secondary outcomes. We're measuring altered measures of methamphetamine use, the subjective effects of methamphetamine use, similar with opioid use, different measures of mood, stress, and pain, retention, my particular interest really this infectious disease related outcomes, measures of functioning, and then adverse events. So really the take home point here are we believe this is a really novel trial using buprenorphine injectable for the treatment of methamphetamine use disorder in the setting of co-occurring opioid use. And we really think this is innovative for these several factors. One, there's a lack of research in polysubstance use groups in methamphetamine use. We're really being responsive to this fourth wave of deaths that are occurring in the United States, where they're really related to stimulant use co-occurring with opiate use. And then the project includes injectable products, which in somewhat eliminates adherence issues, and then partially evaluates this antagonism of the kappa opioid receptor. And we're expected to start enrollment in mid-2021. Well, I really appreciate your attention, and if you have any questions, please feel free. Here's my email, and as well, I'm available here in Sydney through the end of January. So I'm really hoping to meet people and network while I'm here. Thank you.
This is Nadine here. Thank you. I'll just thank you so much, David. I guess we've got a couple of minutes. I can see Anthony's there ready to take us to the next session. But just before we start, we do have some time for questions. I'm asking people to put their questions on to the Q&A function, the question and answer function. So I'll just read out the first question from Denise. Were the people involved in the study residential or non-residential? So are they inpatients or outpatients?
So this is all outpatient. Again, we still haven't started enrollment, and we expect to start in mid-2021.
Okay, thank you. And then a question from Libby. Amongst these clients, do they tend to identify methamphetamine or opioids as the drug they worry about most or wish they could change most?
Yes, so really we're looking for a particular phenotype that we've seen in the Western United States of people who use primarily methamphetamines, and then use opioids, but more on the side and kind of on the come down from the methamphetamine use.
Okay.
So it's primarily the methamphetamine use that people who identify methamphetamine as their primary use disorder.
Yeah. So I guess this is a personal question from me. The rapid induction for the 3-day sublingual buprenorphine straight onto 300 milligrams a month for people that are potentially not severely dependent, are they tolerating that okay?
Well, so we haven't started the trial. This is really the decision to go this fast has come from kind of experts who are doing this in the field. Francis Levin in New York and Andrew Herring in the Oakland area, where they've really had great success kind of going pretty high on initial induction with sublingual products, starting at 8, getting to 16 on first day, even in patients with, and then because we are including patients that they have to have opiate use disorder. On our on CTN 109, this is a little bit different, where it's going to be cocaine only use disorder, and that's going to include long-acting naltrexone plus injectable buprenorphine.
Mm-hmm. Okay, thank you. And a question here from somebody, Lloyd Jones. Do you think it will be difficult to differentiate between treatment effect of the long-acting injectable buprenorphine and just engagement in therapy more broadly?
Yeah, so I think that's been the eternal challenge in our methamphetamine trials, that patients who get into trials seem to do better by being in the trial. But we're hoping that we'll be able to show a difference in difference over the course of the study, right? So hopefully the intervention arm will have a significant decrease in opiate use disorder, in methamphetamine use at the 12-week time point. It's powered to show a difference of at least 10% in the groups.
Okay, thank you. So sorry, that was Martin Lloyd-Jones. The next question from someone Griffiths is, will there be any therapy offered to the participants? I assume that means kind of psychotherapy or more comprehensive treatments than just the medications.
Yeah, so standard in our trials, we provide CBT. And for this trial, they'll be having weekly visits with clinicians to provide CBT. I mean, because of COVID, we're trying to be as virtual as possible. So figuring out how we can do this over Zoom lines. We're also, the other innovative part of this is that probably the urine collection, we might actually be going to where people are instead of having to come to the clinical site, just because of all the restrictions we're having in the US with our clinical trials.
Mm-hmm. Thank you. And then a question from Robert Alai. Buprenorphine's kappa antagonism didn't seem to have a big effect for depression in opioid dependence. What are your thoughts for methamphetamine use disorder?
Yeah, that's really interesting. And I mean, we saw in CURB, in the per protocol analysis in patients who actually were on buprenorphine detected by blood levels, they definitely showed a decrease in cocaine use. So we're hoping and expecting that this will transfer over to methamphetamine use. And I mean, I guess that's why we'll be doing the trial.
Excellent. All right. Thank you. I think any other questions from participants or panelists before we move on? All right. No questions. Thank you. That's fascinating for us, David. And we only are just joining the kind of depot buprenorphine treatment journey for opioid use and opioid use disorder in Australia anyway. So if there are other applications, that would be fascinating for us. Of course, our opioid treatment population is actually quite a high methamphetamine using population as well. And so if there's evidence that it's effective for both conditions, that would be pretty interesting as well for us, I think. So thank you very much. And I'd like to, we would be usually clapping if we could, but we can't. So I'll ask you to turn your screen off so we can introduce the next speaker. Thank you, David.
Thanks, Nadine, and hello, everybody. Greetings from downtown Darlinghurst. My name's Anthony Chambry. I'm the Chief Executive of the St Vincent's Health Network here in Sydney. I'm also a Foundation board member of NCCRED, representing St Vincent's Health Australia, one of the NCCRED consortium partners. I have the lucky role of chairing our session this morning on methamphetamine use disorder and pharmacotherapies. We have two presentations from our colleagues today, and then we have a facilitated discussion at the end. But before we commence, I'd like to thank David for your presentation in leading off our scientific session for our symposium today. Thank you for stepping through your work. And I feel I need to also acknowledge once again your commitment to us by spending time in quarantine. So thank you very much. So we've got 10 minutes allocated to each speaker with some question time at the end. Please feel free to use the Q&A function. Myself or the NCCRED staff will help with asking the questions of our speakers on your behalf. And as a friendly reminder to show respect to our speakers, if you would kindly continue to mute your sound through the presentation. So our first speaker today is Edward Mullen. Edward is going to be presenting on an open label pilot study of sub-anesthetic ketamine for stimulant use disorder, methamphetamine type in youth. Edward is a NCCRED research fellow, a consultant psychiatrist, hype and substance use research group, and early intervention clinic. Please join me in welcoming Edward. Thank you.
Thank you very much for that introduction. I'll just try and share my slides. So, as I said, my name is Edward, or Eddie Mullen. I'm a consultant psychiatrist at Origin, which is a specialist youth mental health treatment centre and research centre down in Melbourne, Victoria. I'm also the pleasure of being the NCCRED, one of the NCCRED research fellows for this year. And this study is a demonstration of some of the work that has come about of that fellowship, and the study is also funded by NCCRED. So part of our work in Origin is early intervention, and part of my work at Origin is sort of providing early intervention to young people with both substance use disorders and dual diagnosis of mental health and substance use disorder. We know it's important because we know that most alcohol and drug use starts in adolescence, and in fact it peaks by the time they sort of leave adolescence to 18, 20, and that's when we start to see the harms come about of financial, mental health, vocational and societal harms. And in fact, sort of even though methamphetamine use is highest and a little bit older in the 20 to 29 group, the use starts much earlier. And we also know that sort of outcomes in this group can be improved by early treatment and early intervention models. So we've talked already, the previous talk talked about sort of treatments for methamphetamine, and I think sort of this is reflected across the way that actually when we think about treatments, people usually think about psychosocial treatments, but when we think about pharmacological treatments, there's actually very poor evidence. And this recent systematic review from last year showed that either sort of most studies are either sort of underpowered or sort of there's methodological difficulties, and there's maybe only a bit of signal for methylphenidate and topiramate, but we do know that there's multiple trials going on at the moment. So our group decided to look at another novel agent. So looking at ketamine as a novel treatment for substance use disorder. So we know ketamine is an anesthetic agent and analgesic, and it's a non-competitive antagonist at NMDA receptors. And in fact, we're looking at sort of glutamate as a mechanism for change in this group. And we know that sort of, sort of ketamine can lead to increased glutamate transmission in prefrontal regions. And when we think about that, we know that glutamatergic dysregulation can actually be one of the mechanisms in substance use disorders, especially when substance use changes to substance abuse, which can lead to sort of issues with sort of treatment and sort of drug-taking behaviors. Ketamine's been shown to be helpful in depression as an accepted treatment now. In fact, can lead to ultra-rapid remission of depression and suicidalation using sub-anesthetic doses, intravenously or subcutaneously or other forms. And our theory being that actually maybe ketamine as a treatment for substance use disorder, and especially methamphetamine use, may actually improve the ability to learn new behaviors in the treatment of substance use disorder and work as an adjunctive treatment for psychosocial interventions. There is some early evidence that actually in rodent samples that intravenous ketamine infusion has been shown to reverse hypodopaminergic state in amphetamine withdrawal in rats. It hasn't been used in methamphetamine or amphetamine in humans, but there has been some early sort of trials and some current trials looking at using it in cocaine users. Was shown to be effective in reducing craving and cocaine self-administration and increased motivation to quit. In people with alcohol use disorder, reduced days drinking and alcohol consumed. And also sort of last couple of decades out of Russia, sort of an opiate use disorder and led to increased abstinence and reduced opiate withdrawal symptoms. So there is some signal there for substance use disorders. Our study is called Mascot. A Mascot, a catchy title. So it's methamphetamine use in young people using sub-anesthetic ketamine open label trial. So as it says, this is a pilot study. It's funded by NCCRED. And what we're looking to do is we're looking to recruit 20 young people, so 15 to 25-year-olds who would normally sort of be our age range at origin, with moderate to severe substance use disorder methamphetamine subtype. These young people are help seeking. And also sort of we'll be recruited through online means and through either alcohol and drug services or through our Headspace centres. If you don't know, Headspace is sort of a primary mental health centre in Victoria and sort of nationwide. The aims of the study is to confirm the safety and tolerability of subcutaneous ketamine administration in young people with substance use disorder. And then as a secondary aim, we're going to try and test the preliminary efficacy of 2 subcutaneous doses of ketamine with initial dose of 0.75 milligrams per kilogram, separated by at least 7 days, to reduce methamphetamine use and methamphetamine craving, with some exploratory aims to try and explore the mechanisms behind the clinical response to ketamine treatment in this young group and try and assess some potential predictors of treatment response. A bit about the intervention. As I said, the intervention is subcutaneous ketamine, and the route of administration and dosing has been based around the work of Colleen Liu, who is an expert in using ketamine for treatment of depression, adult depression, at a Northside clinic. And she, and also sort of at Origin, we have another ketamine study of looking at ketamine for treatment-resistant depression in young people. That's been quite successful and has finished up sort of this year. So all people will receive initially a level 1 dose, which is 0.75 milligrams per kilogram. That dosing has been based on our understanding from the adult depression studies, as well as our own youth depression studies, as well as adult sort of cocaine studies. And the second dose at day 7 will either escalate from level 1 if the initial dose is tolerated to 0.9 milligrams per kilogram, or reduce to 0.6 milligrams if not tolerated. Participants will also be receiving counselling as usual, treatment as usual at the AOD service or Headspace Centre. A bit of a busy slide, but just to sort of demonstrate, there's a lot of safety measures built in that definitely we're looking for people who are methamphetamine use disorder and currently using. There's a screening and assessment procedure to make sure that the right people, that there's a range of screening assessments, medical assessments and blood tests before eligibility is confirmed. There's some safety measures built in around the first treatment visit, which is some urine drug screening, breathalyzer and carbon monoxide breath testing, as well as sort of reports. After the first dose, people will receive 4 hours of monitoring within a clinical trial centre and then be followed up 48 hours after the first treatment. And similarly, after the second treatment at 7 days, they'll also receive sort of follow-up at 48. We follow up using assessment measures at week 3, week 4, and the end of the study will be week 6. The endpoints will be sort of, as I said, primary endpoint is safety. So we'll look at change in ketamine use after administration of ketamine and cravings at week 6 and liver function tests at week 2. Tolerability will be the number of people who are able to stick with the trial, so number of withdrawn participants. And secondary endpoints will be actually around methamphetamine use, so change in weekdays and quantity of use and cravings, as well as looking at methamphetamine abstinence and relapse in our sample and change in use of other substances. We do know there is a lot of safety and ethical considerations, but there is good safety data from our depression studies. The ketamine dosage is quite low and has been shown to be tolerated, especially in this youth population. It's understanding it is a potential drug of abuse, and this is the first time as this is a pilot, so this will lead to better understanding of safety in this population. Progress, COVID has slowed everything down, but we have managed to staff it. There's a project manager and study doctor coming online, waiting final approval from our HREC. There's an online database being developed and the recruitment and communication strategy is also finalised. And we're projecting now the revised start date is January 2021, aiming to finish in December 2021. So thank you very much to the Substance Use Research Group, and I appreciate any questions. Thank you.
Thanks very much, Edward. So we have a couple of questions, and our first question, please, is why only 20 young people for the ketamine trial? Are you looking for a rural arm?
So 20 young people was a pragmatic number. Methamphetamine use in our youth group isn't a primary drug use. As I said, the peak onset is 20 to 29, which is a bit older. So we wanted to be able to run a pilot within the time frame of the budget, and felt that 20 was a realistic target based on our understanding of sort of drug treatment seeking behaviour in Victoria. And the advertisement will be mainly around the metro region, and sort of that we'll expect that people will be sort of attending treatment at local services.
Thank you. Our second question from Denise is, with seeking youth for the study, will youth detention incarcerated people be asked if they would like to participate?
I agree, it's quite an important group of methamphetamine users. I think for the purposes of this pilot, I think we are running it for safety, and it's an untested intervention in youth. So we're running it through a youth population which is not incarcerated at the moment, who we know are engaged in treatment in local services. So I understand it's an important group, but we're not aiming to offer it to patients in the youth juvenile system at the moment.
We also have a question from one of my colleagues, Jonathan Brett, who has asked, are you initiating ketamine after a period of methamphetamine abstinence?
Yeah, so when people arrive for their first dose of methamphetamine, we're asking people to be abstinent for 12 hours pre-dose. As I said, there is a sort of an assessment of self-reported drug use is backed up by urinalysis at that point in time. If there is a report of use within the last 12 hours, we do a sobriety test to assess intoxication, and we have the facility and the protocol to reschedule the appointment if people have used other substances within 12 hours or present intoxicated.
And Edward, we've got time for one more question. This is from Peter Stockham. How does the dose proposed compare to that provided in anaesthesia? And what are the expected effects on the subjects of this dose?
Yeah, that's a really good question. I mean, this is one of the things we've been discussing. Luckily, Colleen Liu is an investigator on this study, so we've been able to use her experience in ketamine as an intervention in this group. So the dose that we're using is about sort of maybe a third of what would be considered a intravenous sort of ketamine dose for anesthesia, and much lower than even intramuscular ketamine dose for anesthesia. I think what's found is that in previous studies in depression, that actually those sub-anesthetic doses are adequate for the treatment response. And in fact, the dose is a little higher than some of the earlier studies, and sort of guided by Colleen knew that actually maybe people are able to tolerate a little bit higher doses than initially thought.
Terrific. Thanks so much, Edward, for stepping us through the work that you and the team are doing with Mascot. Thank you.
Thank you very much.
It's now my pleasure to welcome our second presenter, Liam Ashton, our research officer for the St Vincent's Alcohol and Drug Service. Liam is also a PhD candidate in the National Drug and Alcohol Research Centre of the University of New South Wales. Liam is presenting on LISDEX for the management of acute methamphetamine withdrawal, a protocol for open label feasibility study. Thank you, Liam.
Thank you, Anthony. Let me just share my screen. So thank you so much for letting me present today. My name is Liam, and I'm a PhD candidate at NDARC and also a research officer for the Drug and Alcohol Service at St Vincent's Hospital, Sydney. And today I'll be presenting our protocol for the open label safety and feasibility trial of lisdexamfetamine for the management of methamphetamine withdrawal. So according to the World Drug Report, Australasia has the highest rate of amphetamine dependence worldwide. And in Australia, in people who use methamphetamine, regular use of methamphetamine has almost doubled in the past 9 years. Methamphetamine now accounts for the second most common drug of concern in Australian treatment settings, behind only alcohol. And we know that the abrupt cessation or reduction in use of methamphetamine can lead to significant characteristic withdrawal symptoms. We know that the inefficient treatment of withdrawal symptoms can lead to high rates of relapse, but reduction in withdrawal severity or levels of craving can lead to better treatment outcomes for our clients. Importantly, there is still no evidence-based pharmacotherapy for the management of methamphetamine withdrawal. Agonist therapies, for example, dexamphetamine, have shown promise in the past, but previous studies have been unable to show any levels of efficacy. So we are looking at a new drug called lisdexamphetamine. But why? Lisdexamphetamine is cheap and readily available, and it's currently indicated for use in the management of ADHD and binge eating disorder. Lisdexamphetamine is an inactive prodrug of dexamphetamine. And what that means is when it's first taken, lisdexamphetamine is inert. And it's only once it reaches the bloodstream and that lysine amino acid is cleaved off the lisdexamphetamine molecule that it becomes the psychoactive dexamphetamine. Now, what this means is that lisdexamphetamine has a slower onset of action and produces lower peak dopamine concentrations when compared to dexamphetamine. And this leads to a lower abuse liability and less positive reinforcing effects. And it also allows for once daily dosing. Also importantly, because of this action, lisdexamphetamine cannot be effectively diverted, making it a really great candidate medication for methamphetamine withdrawal. So what we did is we designed an open label, single arm clinical trial looking at a tapering dose regimen of lisdexamphetamine for the management of acute methamphetamine withdrawal. The primary aim of our study is to determine the safety and feasibility of delivering our 5-day tapering dose regimen. And we've got secondary aims looking at the acceptability of the treatment, changes in retention and care, and looking at how withdrawal severity or craving levels change over time, and also the quality of people's sleep. This study was designed and developed with some significant consultation with some consumers, which was wonderful. It let us design a study that not only looked at what we as researchers want to contribute, but also what the people who have methamphetamine use disorder need out of the treatment study. The outcome measures that we've chosen to use in this study were drawn from the most commonly reported measures in pharmacotherapy trials, which we reviewed earlier this year, and Crystal will be presenting on in greater detail later this afternoon. In this trial, we will be recruiting 15 adults who are presenting for admission to the Gorman unit at St Vincent's Hospital, Sydney, for the management of acute methamphetamine withdrawal. We've intentionally kept our inclusion and exclusion criteria quite broad to get an almost real-world sample. And we're looking for people with diagnosed methamphetamine use disorder with recent last use. We're excluding everybody who has an expected concurrent withdrawal from alcohol, opioids, benzodiazepines, GHB, or other gabapentinoids. But importantly, we are still including people who are withdrawing from nicotine or cannabis. We've developed an opportunistic recruitment strategy for this study, and we will be pulling potential participants through our centralized intake service, as well as our stimulant treatment services. And if anybody who is broadly eligible presents unexpectedly, we can also pick them up on admission. So our intervention is a tapering dose regimen of lisdexamphetamine, starting at 250 milligrams on day 1, once daily, reducing by 50 milligrams per day to 50 milligrams on day 5. This dose was chosen because in a previous study of people who were dependent on methamphetamine, this dose was found to be safe and tolerable and to reduce levels of craving. And it's the equivalent to approximately a 74 milligram dose of dexamphetamine. The way the study works is day 0, we've defined as the day that they present to the hospital, and that's when we will undergo all of their screening and baseline assessment. Day 1 of the study is their first full period in hospital, and this is when they will start to receive their medication. Across days 1 to 5, they'll receive a tapering dose of lisdexamphetamine and undergo daily assessments of adverse events, treatment satisfaction, withdrawal, craving severity, and sleep. Participants will then be invited to stay for another 2 days of withdrawal management without any medication. This is so that we can account for any extinction-related adverse events, but also to allow our clients the opportunity to discharge completely medication-free. And this is important to people who want to go straight into a residential rehab where this is a requirement. Our participants may also be prescribed rescue medication in terms of diazepam or olanzapine as required. We will then be following up our participants weekly for 3 weeks by telephone to assess adverse events, but also look at whether or not they're accessing any wraparound health services and looking for any changes in their substance use behaviors. Finally, I just would like to talk a little bit about some novel sleep measures. And this is especially driven from the fact that people are starting to look at sleep as an outcome measure for the efficacy of treatment for methamphetamine dependence and withdrawal. In general, sleep is quite poorly investigated in substance use related research. We tend to use point surveys. I'm sure you're all aware of the Insomnia Severity Index or the St. Mary's Hospital Sleep Questionnaire. And those are good because they give a subjective look at sleep, but they only give it at one time point. And in my discussions with sleep physicians and sleep researchers, this isn't actually how the specialists in this field measure sleep. In lieu of being able to get somebody in for a polysomnography or a formal sleep study, the gold standard of sleep measurement requires a combination of an objective sleep measure and a subjective sleep measure delivered over time. And no study to date has actually investigated sleep in this way in people who are using or withdrawing from stimulants. So in this study, our objective measure is a measure called actigraphy. And what that involves is our participants wearing a little wristwatch. It's kind of like a Fitbit. And it measures heart rate, movement, and ambient light levels. And this is our objective sleep measure. And it's very good at telling when somebody is actually asleep and when somebody is actually awake. We will then get people to complete a daily sleep diary, asking for their subjective experience of sleep, including quality of sleep, when they went to bed, when they think they went to sleep. And this will allow us to pull out the main sleep outcomes that sleep scientists like to find, including total time in bed, total time asleep, but also some really interesting ones looking at sleep onset latency, wake after sleep onset, and sleep efficiency. Now, because in this study, our participants will still be receiving lisdexamfetamine throughout their period of admission, this won't be able to accurately describe sleep in withdrawal. This is proof of concept only. But if this ends up being a feasible way of measuring sleep, this could be a great way in the future to really address sleep in withdrawal. So in conclusion, this study will be the first study ever conducted to investigate lisdexamfetamine for the management of acute methamphetamine withdrawal. If it's found to be safe and feasible, the results from this study will go ahead to inform the development of a fully powered randomized control trial. And in this RCT, we will make sure that we include all of our consumer input and, if it works, our novel sleep measures. And if effective, lisdexamfetamine does have the potential to become the first pharmacotherapy for methamphetamine withdrawal. Finally, I would like to acknowledge the wonderful team behind this project who have made it all possible. And if you have any questions, please don't hesitate to get in touch. Thank you.
Thank you, Liam, very much. And thank you to you and the team. All right, we have a question from Denise, Liam. The question is, clients in the context of a withdrawing residential facility witness to be sleeping soundly at regular room checks. However, their primary concern is not having slept all night. Will the novel sleep measures address these client concerns?
Yeah, and this is, funnily enough, something that the sleep scientists see quite a lot, is a difference between the perception of sleep and the actuality of sleep. So when they do sleep studies, people come in, they go through the sleep study and they say, I didn't sleep at all last night, because they didn't perceive their sleep. But in actual fact, when they go back and they look at the recordings, there are definite periods of sleep. So this will be able to differentiate between any issues with perceiving sleep and actual sleep. And again, we'll also be able to accurately measure if a client fell asleep and precisely how much they fell asleep. Unfortunately, this study is not actually being conducted in a residential rehab, so we aren't going to be able to look at those kind of long-term changes to sleep. This is very much focused on the acute withdrawal in a hospital setting.
Thanks, Liam. And a follow-up question from Denise is, so REM sleep, can it then be recognised?
Yes and no. Again, this isn't a formal polysomnography. We're not looking at brainwaves. So it's nowhere near as sensitive, but it's a trade-off. And we're trading off, you know, a formal polysomnography, which involves a full EKG and many settings, trying to make it more user-friendly.
Great, thanks, Liam. All right, we might now, in the interest of time, move on to our reflection from the session, which is being led by Robert Ali. Robert, of course, is the chair of the NCCRED Methamphetamine and Emerging Drugs Clinical Research Network Working Party, and he is also a clinical associate professor in pharmacology at the University of Adelaide. So please join me in welcoming Robert.
Thanks very much for that introduction, and let me start by thanking NCCRED for putting on this symposium today. I think it's incredibly important. I'd like to pay my respects to the traditional custodians of the land and my respects to elders past, present and emerging. I think that this session really brings together for us a very important opportunity to reflect upon how best to move forward for methamphetamine treatment in Australia. We've heard through the three speakers to date about how Australia has a large methamphetamine problem. Most recent National Household Survey estimated around 300,000 users. And while that's a significant reduction of the proportion of the population that have been using from the surveys back at the beginning of the 2000s, this still represents a significant burden of harm and risk to those who use it. And in that 20 years, we've seen significant changes in the profile of who uses and how people are using, and the consequences of that use. We know now that populations appear to be shifting towards older populations. Back in the early 2000s, 20-year-olds were 11 times more likely to be using than people in their 40s. Now it's about equal, just over equal. We also know that the formulation has changed with the advent of crystal methamphetamine, the higher potency, the rapid route of administration through smoking or injecting, and hence the rapid onset. We've seen the burdens of harms increase. And as we've seen those burdens of harm increase, we've seen also changes in the way people use, with now around a third of people using on a daily or a weekly basis. So while the numbers might have shrunk, we're nevertheless seeing more intensive patterns of use and greater risks and harms. That's led to collateral problems, mental health illness. About a third of people have identified that they were being treated for or had an identifiable methamphetamine problem. We've also seen drugs move from capital cities. So this is now a national problem reaching into regional and remote areas, and the wastewater surveys have confirmed that, and in fact have shown higher densities of use than possibly in the capital cities during the time of COVID-19, which went against expectations that supply and availability might have been curtailed. In the treatment sector, the 1,200 agencies that are providing treatment, we're seeing just over 220,000 people in the last count. That's 137,000 people. And methamphetamine was the second most common reason for principal drug of concern. And our two presenters have really focused on two areas where there is a direct connection. 11% of people were seeking withdrawal treatment, 40% seeking counselling. And we know that in those types of presentations, we don't have a safe and effective medication that's evidence-based and registered for either the treatment of methamphetamine withdrawal or managing those people who need to go on to provide care. So Ed has provided us a really interesting and important innovative study design using ketamine, a medication that's used in other treatment interventions. So we know that it has a profile of use as a medical intervention, but not in this population. And particularly wanting to get ahead of the curve and move towards younger populations who are emerging as having problematic substance use without needing to go on for a longer career in drug use is a really important opportunity. Having that thoughtful approach of stepping through firstly safety and tolerability to see whether or not the medication can be used for this purpose, recognizing its potential for abuse liability is a really critical first step. And I note that they are looking to also look at what impact it has on use and the impact it has on cravings, and explore potential themes for mechanisms of response. But at this stage, I think that small number is appropriate. I picked up in the questions that were being asked at the end of Eddie's presentation about why so small, why aren't we bringing it to scale? But I think it is quite important. While there is a theoretical construct of why it might work, the NMDA receptor mechanism having an impact on dopamine dysregulation, I think has a theoretical construct. We still need to see whether it plays out and whether it can be managed if it's tolerable and it's safe for this population, and then build on that to what other populations it might be effective for. Lam's proposal and the research group they're using lisdexamfetamine for managing inpatient withdrawal also builds on a backdrop of not having safe and effective medications. And in fact, within Australia, you'll see a great variety of medications that have been used to try and ameliorate the severity and the symptoms of withdrawal, and particularly to help people, as a lot of his presentation concentrated on that issue of sleep dysregulation and how they, particularly when they're placed in environments with people who are withdrawing from sedative type drugs, the juxtaposition of people being awake when others are asleep and asleep when others are awake is disruptive for the environment of managing people, potentially leading to conflict, and early leaving from that withdrawal setting is something that I think is quite important to overcome. All the people that I know that work in withdrawal environments have been anxiously looking for a better way of doing it. And again, this study is really, while being open label and single arm, is trying to firstly look at feasibility and safety of using this medication, and then move into secondary aims of acceptability and the potential to keep people in treatment. So I think both of these studies have the potential to provide us with important new first steps. I'm heartened by the fact that they are connected to the work that NCCRED are doing, which I think is incredibly important, of shining a spotlight on areas where we can see a large burden of harm, but uncertain about best next steps forward. These have good foundations for doing that. I'm hopeful that they will be able to stay on track given the circumstances that we have of COVID and the limitations that places on recruitment and conducting research in a very difficult environment. But I think we have good reason to be optimistic that we will be able to see their results in due course. And I'll hand back to you. Thanks, Anthony.
Thank you, Robert. Thanks for sharing your insights and reflections on our first two presentations. And of course, thank you for all that you do for NCCRED. We are very grateful. Ladies and gentlemen, that's the end of our first session. Thank you to Edward and Liam for kicking off our presentations today. And we are right on time, so Nadine will be happy with me. And it's my pleasure to now hand over to my colleague, Anne Roche, who of course is also an NCCRED board member. Thank you.